Hi, everyone. Thank you so much for tuning in to Endo Smile Podcast. My name is Kisa Iqbal, and I'm so excited that you're here and that I'm finally doing this. I've been thinking about doing this for a while now, and I thought, why not just jump right in? So, I am a general dentist, and I am specifically interested in the field of endodontics. And so, the purpose of this podcast is basically to allow me to present different topics about endodontics and hopefully create some videos and content about certain literature and do some literature reviews and basically get a little bit more of a deeper understanding about endodontics. And I hope you learned something. I know I'm going to learn something, whether that be about endodontics, about how to use the computer, how to upload on YouTube. So thank you so much for tuning in. I hope this is helpful for everybody. So I'm going to go ahead and get started. So the topic of today's discussion is going to be focused around antibiotics and endodontics, and specifically clarifying its use, appropriate use. So based on my experience, sometimes I will have patients come in holding their head in pain, holding their jaw in pain, unable to sleep the night before, and basically I've heard or have experienced certain situations where when we hear pain, the suggestion is, oh, give him or her a round of antibiotics. And to me, I think that warrants some investigation and some clarification to see when antibiotics are appropriate and why are they used, and being a little bit more careful about certain situations that warrant the use of antibiotics and certain situations in which they aren't warranted. And so we're going to go into deep depth about this topic. So we're going to get started. So the source that I used to create this presentation was primarily with Pathways of the Pulp, the 9th edition, written by Stephen Cohen and his colleagues. And a quick disclaimer is that this presentation is for the sole purpose of learning and discussion. I by no means am an expert. I'm just trying to present some information that will be useful to me and hopefully to others as well. So, the two important factors and concepts in endodontics that I wanted to start my presentation off were, number one, obtaining the correct diagnosis. So, by doing different tests and asking certain questions and getting a thorough medical history and basically creating that big picture that will allow us to create and lead to a correct diagnosis is so important, because that way a correct diagnosis can hopefully allow us to present the patient with appropriate treatment plan or treatment plan options. Secondly, the most important factor is removing the cause of the endodontic infection. And so primarily that being bacterial in nature. So I love this schematic. So I love that they're able to kind of show the connectedness between symptoms, the problem, and the cause. And specifically, I like how the roots display highlight the cause. And like I said, in endodontics, that's bacterial in nature. So our focus is going to be about how do we remove these bacterial toxins and inflammatory factors and all of these things. How do we remove that, whether that be through mechanical means, through non-surgical root canal therapy, surgical root canal therapy, and how antibiotics kind of intertwines and links with our attempt to remove bacteria. So I think the slide is great and it highlights two key important ideas. So based on my readings, I found that most endodontic infections can be treated without the use of adjunctive antibiotics. And furthermore, analgesics, not antibiotics, are indicated for the treatment of pain. So, like I alluded to earlier in this presentation, when a patient comes in pain, antibiotics aren't addressing that. The key thing to address pain and address pain management is analgesics, whether that be NSAIDs, non-steroidal anti-inflammatory drugs, or non-NSAIDs. And so I want to make that clear. Antibiotics are not for pain management. So this is a list of when antibiotics are not recommended if seen just independently. So in cases of irreversible pulpitis, that's a big one, acute apical periodontitis, draining sinus tracts, after endodontic surgery, to prevent flare-ups, and also after INDs, known as incision and drainage, of a localized swelling, and that's with the assumption that it's without cellulitis, fever, or lymphadenopathy. So I think that this is a great list. So these are when antibiotics are not recommended. The next slide is going to address when are they appropriate. So in addition to endodontic treatment, so like I said, I'm going to highlight again, not independently, but in addition to endodontic treatment, antibiotics are appropriate when there's progressive or persistent infections with systemic signs and symptoms. And those include a patient presenting with fever, 100 degrees Fahrenheit or above, or 37.8 degrees Celsius or above. Also malaise, cellulitis, unexplained trismus or limited mouth opening, or progressive or persistent swelling. So keyword here, systemic. This slide highlights an IND, incision and drainage, and I think the schematic is great because it highlights, and it's a good analogy to explain what's going on. So when I think of cellulitis or abscess, or thinking about what an IND is and what it does, it's basically the purpose of it is to decompress certain tissue that may be expanded and creating pressure from that edema, and that can be causing pain to the patient. And so what an IND does, less so in a sporadic way like this, but in a more purposeful way, it allows the bacteria, bacterial byproducts, and inflammatory mediators to have a route in which they can be removed and basically removed from the body. And so if an IND is not done, it can lead to further spread into different head and neck facial abscesses or into other parts of the body. So an IND, like I said, allows a conduit and a passage for these negative toxins and basically these byproducts, a way in which they can be removed from the body and away from the site of infection. Okay, I think this is also a nice link between an IND and how that relates to antibiotics. So an IND is appropriate because it can actually improve and create a better delivery of the antibiotic drug. And the way in which it does that is because when there is an abscess or edema, that fluid and pus can cause a decrease in blood flow. And what that does, it can prevent what's called minimum inhibitory concentration, or MIC. You might have seen this in pharmacology textbooks, this concept. So it may prevent an MIC of antibiotic. And the way in which that happens is, if you look at this bottom picture and picture the paper plane to be the antibiotic, it's going through a lot more trials and obstacles to reach the desired site of delivery. So if you think about edema and pus and those inflammatory factors that we talked about, they can basically be a roadblock and prevent the antibiotic from reaching that area. And what an IND does, it theoretically removes all this middle ground roadblocks and allows a more smoother delivery of the antibiotic. And that drainage can be very beneficial, and it can be an IND and antibiotic administration can be used together, and they're definitely related. This picture is great to highlight how an IND is performed, and there's a lot of details that we can go into. But in the general sense, if we have an endodontic infection and that inflammation is passing into those fluids, we can have an abscess like so. And what you do in an IND is that you basically create a stab incision into the periosteum with a sharp blade, barred Parker knife, or scalpel, and you really just create that stab incision right into that lesion. And you can use a curved hemostat or a periosteal elevator, and really you're opening that area of incision up and allowing that drainage to occur. A rubber dam or a Penrose drain can be used and placed to allow that continuous drainage. And I think it's also important that patients should be followed daily to ensure that the infection is resolving. So even as a clinician, a quick phone call at the end of the day, I think goes a long way. It creates a great rapport with your patient, and it shows that you actually care. And you, in certain situations like this, you really do want to follow up because, like I said, these infections can spread into other parts of the body and other fascial spaces. And so keeping up with your patient and seeing how they're doing can help prevent further complications and, like I said, build that rapport as well. So the title of the slide is ideal versus realistic. So in an ideal world, we would do susceptibility testing. So ideally, we would grab a sample from the lesion of interest and basically inoculate it and see which antibiotics are most effective to the bacteria that are present. And if you remember the courses about microbiology and all of that, so that's ideal. But the disadvantage is that it can take several days or weeks, and also many organisms cannot be cultivated, in the sense that in the bacteria that are found in endodontic lesions, anaerobic, aerobic, primarily anaerobic, sometimes aerobic, but mostly anaerobic and facultative bacteria, a lot of the bacteria aren't able to be cultivated. So those are the two drawbacks. And also, when we're talking about antibiotics, we also want the patient to know the benefits, the risks of taking antibiotics, and also the potential side effects as well. And that all links into informed consent and being completely thorough in transferring that information to your patients. And also, I think this is key here, problems if proper schedule is not followed. So like we know, antibiotics, oftentimes multiple doses a day, 2 times a day, 3 times a day. There's a certain regimen that antibiotics should be followed, and patients need to be aware of that and should know that if they aren't following that scheduled protocol, what are the potential drawbacks if they don't do that, and just highlighting the importance of that. So potential side effects of certain antibiotics are going to be discussed on the slide. So rifampin studies have shown that its use can reduce the effectiveness of oral contraceptives, and some research has shown that other antibiotics have also shown the reduction in effectiveness. So patients should be advised to use other methods of birth control as well. Clarithromycin and azithromycin may block metabolism of warfarin and anisindione, which are both anticoagulants. And so blocking the metabolism, that can cause really big risks in bleeding. And metronidazole should not be consumed with alcohol because patients can experience nausea, dizziness, headaches, etc., and should not be prescribed for patients taking lithium. Lithium often prescribed for mania and different mental health related schizophrenia and different situations. Timeline. So this is the general timeline. So antibiotics generally are taken 6 to 10 days around the clock. Like I said, oftentimes, every 6 to 8 hours, and we're going to go through some of those details in the next few slides. Improvement should generally be seen within 24 to 48 hours, and like I said, in conjunction with the endodontic therapy. And also a key thing to note is a high dose regimen for a short time is preferred over a low dose for a longer time. And oftentimes the antibiotics need a loading dose to initiate effective serum levels, followed by a maintenance dose. So let's get into some specifics and some details. So penicillin VK or Pen VK, this is the antibiotic of choice because of its efficacy and low toxicity. And like I said earlier, the bacteria in endodontic lesions are primarily facultative and anaerobic, so without oxygen or they can survive with or without. And another key thing to note is that they found that penicillin can have an allergy rate up to 10% of the population, and that's a major concern, of course. And so we're going to talk about the alternatives, medications that you can prescribe to patients with these allergies. So the loading dose for Pen-BK include 10,000 milligrams and 500 milligrams every 6 hours for about 6 to 10 days. In severe infections, that can be changed to every 4 hours to maintain a higher serum level. Amoxicillin, similar suffix as penicillin, same family, are broad spectrum. They have a broader spectrum of activity. They're absorbed more rapidly, and provide a more sustained serum level. And it selects for more resistant organisms, such as those found in the GI tract, and they may be indicated for immunocompromised patients or medically compromised patients. And so the loading dose for amoxicillin is 1,000 milligrams and 500 milligrams every 8 hours for, again, 6 to 10 days. Here I want to highlight the use of amoxicillin along with Augmentin. So these have recently shown to have the best efficacy, and it may be indicated to treat serious endo infections. And clavulanate is also can be the nomenclature can be clavulanic acid as well. So those are synonymous. Moving on to the antibiotic group of macrolides, we have clarithromycin and azithromycin. So they're effective against some anaerobic bacteria, but they don't have the best long-term track record. However, they can be used for mild infections and patients allergic to penicillin. And they've been shown to be better than erythromycin in the sense that they have been shown to produce less GI upset. And so the dosage, clarithromycin can be taken with or without meals, and that's 250 to 500 milligrams every 12 hours for 6 to 10 days. And azithromycin can be taken 1 hour before meals or 2 hours after meals. And the loading dose is 500 milligrams on the first day, followed by 250 milligrams daily. I hope you guys are hanging in. A quick recap. So we talked about Pen-BK, amoxicillin, and clarithromycin and azithromycin. Also on my last slide, I have a quick summary of all these dosages and milligrams. So that way, it's all in one space. Okay, metronidazole. So metronidazole is active against strict anaerobes, but not facultative bacteria. And it can be used with penicillin if penicillin has been used for 2 to 3 days without improvements of signs and symptoms experienced by the patient. So metronidazole should be introduced after the diagnosis has been reviewed and drainage established. So it's almost like a little extra oomph. Like if penicillin is not doing, it's not showing, the patient's not getting better, metronidazole is a little bit of that nitrous boost that, when you get that in those video games where you like hit the nitrous and it kind of, your car kind of zooms forward. I kind of see that as metronidazole. But like I said, we want to be careful that if penicillin's not working, it's warranted that we review the case and make sure that we did get that correct diagnosis before we introduce another antibiotic. And the loading dose for that is 500 milligrams and 250 to 500 milligrams every 6 hours. And clindamycin. So it can be used for patients who are allergic to penicillin, um, similarly to clarithromycin and azithromycin that we talked about in the previous few slides. However, clindamycin is it can be differentiated from the other two macrolides in the sense that it can be used for serious infections, while the other two were for milder infections. But the thing is, studies have showed that clindamycin can be associated with colitis or pseudomembranous colitis. There has been a link, but also in my readings, I found that it wasn't just specific to clindamycin. Other antibiotics have also been associated with clindamycin, with colitis, excuse me. Um, and also found that based on the dosages that we use for endodontic infections, the dosages are considered small enough that it would be rare for clindamycin to cause colitis. So that's a little bit, I think this area is a little bit hazy. Um, so, so it's not to say that clindamycin is uh, unique in that it's been linked to colitis. But I've also read in the same text that the dosages that we use are small enough that it's rare that it would lead to colitis. So the loading dose for clindamycin is 300 milligrams and 150 to 300 milligrams every 6 hours for, again, 6 to 10 days. I say 6 to 10 days enough. All right, so this is the summary slide that I was talking about. You can go ahead and screenshot this. I have a little cheat sheet in my clinic just so that I have, like a quick reference, just so I can double check on the loading dose and the maintenance dose. So quick recap, we've got penBK, amoxicillin, clarithromycin, azithromycin, metronidazole, like I said, in addition to penicillin and clindamycin, and these are the different dosages again. So depending on certain situations, what types of medications the patient's taking, their allergies, whether they've seen improvement or not, whether they have GI issues or sensitive stomach, all these different factors can help guide you to prescribing a more appropriate antibiotic. And I think that just highlights, as dental practitioners, the importance of receiving a thorough medical history and really having a big picture idea of what's going on systemically. I know sometimes we look very narrow in on one tooth or the teeth in general, but as practitioners and as medical care providers, it's our responsibility to see the body as a whole, and I think that would make us better practitioners. So thank you so much. Thank you for bearing with me, and thank you for tuning in. I'm super excited to start this channel, and I'm hoping to upload a few more videos, hopefully review some medical research. My next topic I think I'm going to be interested in is exploring regenerative endodontics and getting a better idea of the current research and the past research about that. So thank you so much. I'm going to link the email to this channel. It's going to be called endosmilepodcast@gmail.com. I'm going to link that. If you want to send me an email, feel free. Thank you so much. I hope you have an awesome day. I wish you and your loved ones all the best. And thank you so much. Take care. Bye.